I'd like to invite Dr. Shane Mathew to give us talk on the algorithmic approach to managing retinal venous occlusions.
Good afternoon to all. I think I'm the last batsman and lack of time, so I think I'll have to run it through. Yeah. So I called venous occlusion the Tanduni of retinal diseases because it doesn't obey any laws. They talked about good, bad prognostic markers. RVOs, it's always an enigma because BRVOs may need large number of injections, and CRVO, some of them may not need that much injection. And some of the BRVOs, visual acuity will be very low. Some of the RVOs, you get 6/6 vision as well. So I thought of possibilities. There are 40 scenarios which came to my mind, so literally impossible to cover in the next 10-15 minutes. But I thought I'll put in few algorithmic scores to you to go back and think about it. So I'll quickly go through a diagnosis which is very easy. It's a sure shot diagnosis, CRVOs, HCRVO and BRVO. Hemicentral vein occlusion has to have the same management protocol as that of a CRVO. But this is a peripheral venous occlusion. We can see literally asymptomatic patient. You don't have to do anything about it unless a neovascularization develops. An impending RVO is a new entity or a venous stasis retinopathy which we have to identify, not for the treating the eye. We may not do anything for the eye, but to treat the systemic condition responsible for this. This patient had an acute myeloid leukemia. So it is important. Many a times you may see a normal fundus, especially in a subtle old venous occlusion. Here multicolor imaging comes into play, and the green reflectance clearly shows the sclerosed vessels. So when in doubt, a multicolor imaging can give us subtle clues. They can exemplify the subtle clues to give you a diagnosis. It is important to divide RVOs into a young and bilateral RVOs to an old or people over the age of 50 who develop an RVO, because the etiology may be slightly different. Young RVOs, the prognosis is better and a better reparative process when compared to older age groups. And the uncommon etiologies are found in mostly young patients. In an old age group, more and more studies are coming out saying that the propensity of developing a cerebrovascular as well as cardiovascular complications are more in the old age group. So please send them for a risk analysis to a cardiology or a stroke clinic. That is important as a part of systemic evaluation. Now, you're all aware about the routine investigation you send for a case of RVO, but I would like to draw your attention to a few of the features. Plasma homocysteine level. Recently, a study from North India said that 80% of the healthy doctors had hyperhomocystinemia. It's a very common entity. Don't forget to send for a serum homocysteine level. Same way, subclinical hypothyroidism. Patient may have normal T3, T4, but the TSH may be slightly. These are all rare, but not so rare causes for retinal venous occlusion. So please look into that. A hyperhemoglobin level, which is, this part of Kerala, I think this is a very common thing. So please look into all this in cases of RVOs. It is important to stratify retinal venous occlusions into a high-risk variety and a lower-risk variety, the so-called non-ischemic one or ischemic one. Why? Because we are talking about multiple number of injections. You see, studies said that almost 50% of the patient required still injections after 4 years. So we are talking about a long duration of follow-up, treatment burden as well as logistic burden for this older generations. Non-ischemic RVO, better vision, no RAPD. Ischemic RVO, greater reduction in vision, RAPD, B-wave abnormalities. Conventionally, we need to follow up monthly these patients for 6 months for BRVOs or less severe RVOs, and up to 1 year for a CRVO on a monthly interval, and to continue up to 3 years. So we are looking at, again, a long follow-up period. So how do we stratify the patient so that we can judiciously follow them up less frequently? For that, to look for ischemic conversion is extremely important. There is a growing interest on looking at capillary non-perfusion in the periphery for CRVOs. This is done by an ultra-wide field angiography. I'm sure many centers may not have it, but if it is there, please utilize it. You cannot do an angiogram immediately once you see an acute CRVO because the images may not be clear. So after a couple of doses of angiogram, or as the RVO settles down, you can do an wide field fundus fluorescence angiography. An ischemic index is the ratio of a non-ischemic area divided by the area of ischemic area. And studies have shown that if it is less than 10%, these type of RVOs with macular edema may respond better to anti-VEGF injections. And if you find that there are more than 75 disc diameters of capillary non-perfusion, which is roughly 1/4 of the size of this ultra-wide field image, you know that the chance of neovascularization is more. So you need to follow up or stratify as a high-risk category group and need to follow up monthly interval. Yeah. So the next thing to look for during a follow-up visit is collateral formation. This is a sequential picture of a BRVO patient. The last picture shows a disc collaterals. The moment you see collaterals, you know that the reparative process has started, the disease has started slowing down, and may need lesser follow-up visits and injections. Retinal capillary macroaneurysms are the ones which are seen on the small round there, and this is of paramount importance. Again, a reparative process, but they may exude and the causes for macular edema. So a focal laser to that may save your day as far as management of macular edema is concerned. OCT angiogram helps us in finding out capillary non-perfusion, especially at the foveal avascular zone, intercapillary vessel density, and deep capillary plexus vessel density. Intraretinal neovascularization can be picked up with these, and suspected neovascularization could be confirmed by doing an OCT. But I repeat, OCT angiogram in the present times cannot replace an ultra-wide field angiogram because it cannot capture the extreme periphery capillary non-perfusion areas. Important aspect is macular edema in the management of RVO. If there is presence of macular edema, you need to treat. So there are some poor and good prognostic biomarkers in AMD as well as DME, which Dr. Unni and Dr. Prakash said. But I said this Tanduni doesn't have any of those factors. Many studies have looked into that. But I would like to bring it to your notice two important facts. Any edema with RVO needs to be treated initially. After a couple of injections, then you look for ischemic indices. So this is the first is ischemic index, which is a drill within 1 millimeter of the center of the fovea. And this is a PAM-like feature, paracentral acute middle maculopathy, and this is the hyper-reflective inner retinal layer. So after a couple of injections, after the edema has subsided, you see any of these features, these are the candidates. You need not inject aggressively because their visual acuity is not going to improve from there on. Also, studies have also shown that central retinal thickness and the size of the cyst as well as the percentage of the drill by around 4 to 6 months of treatment can predict the long-term visual outcomes in these patients. So as long as the visual acuity keep improving, keep injecting, and on 2 consecutive visits, if the visual acuity is going to be same, you may try stopping an injection at that time. And always think about a re-occlusion with macular edema. If that is the case, I would treat it as a fresh CRVO once again. The dictum is to give a monthly injection for 6 months and to continue monthly, which is almost impossible to do. So that is the best form of treatment. But studies have also shown that a monthly injection for 3 doses followed by a treat and extend can reduce the number of injections as well as the follow-up burden. But this seems to be less inferior or inferior to the monthly injections. Again, retained study 4-year data is telling us that 50% of the patients still had persistent macular edema. So we are talking about a long-term follow-up and treatment. The moment you decide to stop your anti-VEGF treatment, edema has subsided, please follow this up closely because there is a risk of neovascularization developed because of the VEGF upregulations. You stop treatment with anti-VEGF, don't follow them lately, but follow them closely. So the first evidence of neovascularization, you need to treat. So there are certain studies and groups came up with different strategies to reduce on the number of injections and follow-up. One such is to divide the responders into 3 different categories. A good responder, after 3 injections, 0 edema. They stopped injection immediately and then went for a PRN regimen and increased the follow-up visits. The second people, they had a partial responders. They gave 3 more injections. So they gave monthly 6 monthly injections, and then on they started on a PRN regimen. And the other one was a non-responder after 3 injections. So they immediately switched their medication to a steroid agent, or they went into a higher imbibing agent such as brolucizumab. Still, there is a role for macular edema treatment with laser. Recurrent macular edema in a BRVO, I still might try a little grid laser or a focal to retinal capillary macroaneurysm. Peripheral PRP for CNP areas of RVO with recurrent macular edema. So the next you look on a revisit is the chances of reocclusion. So this gentleman, first picture RVO, treated 3 injections, responded well. On the 5th month, started with reocclusion. So this is reocclusion of an existing RVO or a venous occlusion is some thing which you have to look for. Whenever you see that, revisit the systemic status, and these patients may not regain a pre-occlusion vision, and there is high risk for neovascularization. You see neovascularization, panretinal photocoagulation is the treatment of choice with or without anti-VEGF. And I would like to end my talk by saying a note. Neovascular glaucoma in these patients, there is a tendency to give anti-VEGF along with PRP. But anti-VEGF sometimes may become a double-edged sword. The existing open angles in a neovascularization, neovascular angle can get closed just after you give anti-VEGF. It is not that you should not be giving anti-VEGF. You should prime your glaucoma colleague to immediately intervene and do a glaucoma shunt or filtering surgery, because many a times the disc in RVO patients are labile. They undergo infarction with a few days of increase in intraocular pressure. So we need to think about a lot of things in treating these diseases, and an algorithmic approach in using newer investigative modality, newer insight that we received from these modalities to optimally managing the disease. Thank you.
Thank you, Dr. Shane. Just one question regarding the treatment of edema with RVO. Is there any circumstance where you would prefer Ozurdex as a first line of management rather than anti-VEGF?
Yeah, first of all, I would take into consideration the patient factors. Second, I would like to think about the inflammatory markers which I see on OCT. And also, phakic status, pseudophakic, I'm more in favor of giving an Ozurdex.
Thank you. Thank you for the nice talk.